最初の質問は amenorrhea, primary and secondary。はい。じゃあ、この、だから amenorrhea is when you have a lack of bleeding and you miss more than 3 menstrual cycles. And in people who are previously bleeding, we can separate amenorrhea into 2 different types, primary and secondary. Primary is when you have never had any menstruation, and in secondary you had menstruation before, but now you don't have it anymore. And primary amenorrhea can be divided into uh, 3 different types. And the first type is congenital malformation, anatomy. So you may have a vaginal septum, transverse vaginal septum, which means that, or you may have a Mullerian agenesis, which means that you don't have a uterus or vagina, and this will obviously lead to amenorrhea. And you may also have imperforate hymen, which means that the blood will not flow into the だからその it's not perforated. So, and this other type is when you have uh, no secondary characteristics. So you have when you don't have puberty, such as pubarch, which means the growth of pubic hairs, or menarche, or thelarche, which means the growth of the breast, then you will have this type by the age of 13. Then you will have this type of a primary amenorrhea. While in the second type, it's you have these secondary characteristics like thelarche, breast budding, pubarch, butt, and growth of the height, but you do not have this menses. And the causes can be a lot of things. And for secondary, so as I mentioned, it can be categorized to either dependent on androgens versus not dependent on androgens. So what does this mean? So what does dependence on androgens mean? So it means that the level of testosterone will be high, and this will result in the suppression of estrogen, which is required for the menstruation to occur, and conditions in which the testosterone levels will increase are things like polycystic ovarian syndrome, or congenital adrenal hyperplasia, and conditions in which uh, testosterone levels are not high, but there are still amenorrhea, can include things like hypothalamic lesions or pituitary lesions, and such as if you have a problem with the pituitary due to surgery or radiation or trauma, and it releases low levels of hormones like gonadotropin releasing hormones, then this can lead to the lack of luteinizing hormones and follicle setting hormones, which is necessary for the menstruation. And for the treatment, we can talk about each disorders, and each disorders will be necessary different treatment. And For the anatomic problem, then we will have to perform surgery, so a hymenectomy or removal of the septum. And if there are no uterus, then there's no cure for this. But for primary ones that are dependent, that do not have secondary sexual transformations, we can give uh, we can give uh, things like we can give things like follicle stimulating hormones or human menopausal gonadotropin, which are necessary for the development. ちょっとよくわかんないんだけど、まあいいや、そこまでにしとこう。で、次のトピック、10 Children's Gynecology, Inflammation, Bleeding, and Tumors. だから小児婦人科、炎症、出血、腫瘍。あ、そう。小児婦人科、炎症、出血。先生、無月経のやつ。8から15で15までって言ったの。だから昨日は8しかやってないから。だからその小児婦人科、小児ね、Children's Gynecology と Inflammation、炎症、Bleeding、出血、Tumor、腫瘍。婦人科、小児の婦人科。だから、so in children's gynecology, we will examine the patient either in the frog leg position or in the reclining position with the curtains around. And usually the parents can also hold the child during the examination. And we can have many different types of lesions around the genitals. And I would like to start with infectious causes. So we can have vaginitis, or vulvar vaginitis, which is the inflammation of the areas around the vulvas. And this can be due to many different types of infections, such as Escherichia coli, or even so, depending on the child's age, it can cause different microorganisms, can cause different inflammations, and also if the inflammation is deeper than this, then we can call it a vaginitis. And one of the things that can also happen is things like lichen sclerosis or lichen simplex or lichen planus. This is basically what it means is that when you scratch the area too much, then the skin around the vulva will thicken and it will create this area of flakiness. And in lichen sclerosis, this is when you have skin that looks white, and this is most commonly found in older people, but may also be found in children. And in lichen planus, we uh, we can mention other things and other causes of bleeding. So if we have bleeding in children, it can be due to conditions like when you have bleeding during the newborn period, then that means that the mother's estrogen uh, had caused a hypertrophy of the uterus of the newborn, and when the baby was born, then this lack of estrogen from the mother caused the breakdown of the uterus and caused bleeding. And in children, uh, it can be due to things like precocious puberty, like if you have um, diseases that may cause precocious puberty, then this can also happen. It can also be due to tumors and and yes, so 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 those are some things that can happen. これはあんまり良くないんだよね。ここまでです。いや、良くないと思う。まあでも今はこのレベルなんだけど。はい。で、次、だからこの11を飛ばして、12、尿失禁、定義、疫学診断。So,尿失禁, urinary incontinence definition. So, urinary incontinence means involuntary voiding of urine that may cause problems either socially or um, social problems. And we can divide the urinary incontinence. Also, the epidemiology of urinary incontinence, first of all, is that so it's very common as the female ages. So in the 20s to 30s, maybe 10% will have this incontinence. In the 40s, maybe 20% will have incontinence, and above 60, 40% may have it. 30% may have it, and by ages like in the nursing homes, then there may be above or around 40% of the patients may have it. And we have 3 different types of urinary incontinence. First type is stress incontinence, meaning that when you have an increase in the abdominal pressure, and this causes the urination to leak out. And the second type is when you have a overflow incontinence, meaning that your bladder cannot contract properly, and this will cause the filling of the urine, and So every time it's full, you will have to go to the toilet, but you cannot completely void. And the third type is when you have a overactive bladder, and this means that your bladder is not completely full, but it is constantly contracting, causing this constant urge to urinate, and this can cause problems because you have to always know where the toilet is, and you have to, every time you go somewhere, you have to map out and research where the toilet is, etc. So, how do we diagnose each of these? We again can have clinical diagnoses, and the doctor will ask some questions and will ask if you will ask you to cough or may perform a Valsalva maneuver, which means that you will press onto the abdomen and it will cause increased abdominal pressure, and this will cause a uh, this will cause the objective observation of the urine to come out, and we can then say that okay, this patient has stress incontinence. For the for the uh, overflow incontinent, we can either do a test where we can insert a catheter into the bladder and fill the bladder, and usually at around 150 milliliter of water you will feel the first urge to urinate, but in overflow bladder this will not come, and usually the bladder capacity is around 400, so it will usually fill up to this point. And for the last uh, overactive bladder, we can do the same thing. So we can fill the bladder with water, and usually when it's even before 150 milliliters, it will have a contraction. And we can also perform a pressure test and see whether if uh, the avoiding so the usually during urination the pressure will rise, and when you're not urinating then the pressure is leveled, but in these patients with avoiding problem I mean the overactive bladder, then it's always contracting, so the pressure will rise to around 80 millimeters centimeters of water. And so those are different diagnoses, and for treatment, we can talk about. So for stress incontinence, we can do some conservative treatments like giving a tool inside the vagina, which will compress the urethra from underneath. We can also perform Kegel exercises, which means perineal muscle exercises, and also we can perform surgeries. And in surgery we can have different types, like if you put a sleeve around the tape around the urethra and attach it to the uh, uh, Cooper's ligaments or into the pubic symphysis. This is one way. Another way is if you use a tape that is inserted through the vagina, and then yeah, so as like a sleeve in order to basically lift up the urethra so that it doesn't spontaneously leak fluid. Some other surgery methods are performed, but it's quite rare, especially the anterior um, uh, anterior wall where you will there's an increased risk in this procedure to damage the urethra and therefore is not performed. And for the next one, which is the overactive bladder, so we can have treatment methods which are conservative, like biofeedback. So, or we can also have some psychological problems, or if there's an obstruction, then we can relieve this obstruction. And there's also drugs that can relax the bladders, and some will include things like anticholinergic drugs that will allow the bladder to relax. And also there are some antidiuretic like desmopressin, which is used for the treatment of nocturia. and and also if uh, so those are some medications that can be used. And for surgical treatment, we may apply. Okay, so we may also apply Botox A into the detrusor muscle to relax that muscle. And so, and surgically, we can perform things if there are obstruction in the urethra. And so, and for the overflow incontinence, it's usually done by inserting a catheter and voiding in this way. So this is usually the only option. And for question 12, 13, and 14, it's the same. そう、だから今喋ったやつ、だからこの腹圧性尿失禁と切迫性尿失禁の診断と治療、まあ、13と14。で、number 15, dissensus prolapse of これ意味わかんない。ああ、そういうことか。prolapse of parents and risk factors, cystocelia and intercilia. So, what is dissensus prolapse of parents? So, dissensus means that the organ within the uterus, so basically when your organs are displaced from the usual position, this is what prolapse means. And some risk factors. Okay, so some organs that can prolapse in gynecology can include things like urinary bladder, uterus, vagina, rectum, intestines. So those things can prolapse through the perineum, which is the lower part of the body, the pelvis. And some risk factors include being multiparous, so you have had multiple births. If you're old age, or if you are white race, because Asians or Black people tend to have less of this. If you have a connective tissue disorder like Ehlers-Danlos syndrome, if you smoke and you cough a lot, or you have constipation, and you have an increase in the intra-abdominal pressure, then this can also cause prolapse. And if you've had surgery in the organs, or injury, then this can also be a risk factor. And also pregnancy, so the physiology behind this multiparous is when you have a lot of pregnancy, there's a lot of nerve damage, muscle damage, ligament damage. And also when you release hormones like progesterone or relaxins, this will also soften the ligaments within the uterine walls. And so those were some risk factors. And about each, uh, we can have cystocele. This is when your bladder will prolapse, and when you have prolapse, then you have to so basically push it back in. And if it's very mild, then usually it's not surgery is not done because it will if the pain there's not that much pain, like some mild pain in the back or some protrusion, then this will be not treated. And some symptoms will again be like you can see the protrusion within the vaginal wall, and this will cause some constipation or some urinary blockage. We can also mention uh, the diagnosis is done by a clinical examination, so you can see that there's a prolapse when you examine the pelvis, and for treatment methods, we will so for cystocele, this is when your bladder is descended, and so the upper part of the vagina is being like coming out prolapse, and this for this we will perform a incision anterior um, anterior vaginal wall surgery where you will open the vaginal wall and then you will um, shorten the pelvico-fascial uh, pelvico-vaginal fascia, and we will adjust the position of the bladder. And this is not indicated in patients with stress incontinence because this may damage it may worsen the stress incontinence. And after that, you will close the vaginal wall. And another method that can be used is by suturing the bladder to other ligaments, such as the sacral spinal ligament suspension. We can also uh, so that is one example. And for the enterocele, so this is when the intestine is prolapsed through the Douglas pouch and then outside into the vaginal wall, posterior vaginal wall. So this is in a sense a true prolapse, and this is repaired by a posterior vaginal wall surgery where the part of the peritoneal sac is being cut and sutured so that the 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 intestine will not prolapse. And other prolapse that can happen are things like uterine prolapse is when the uterus will collapse through the vagina. And again, so the basic treatment methods for each of these is like you will suture the organs into either the sacrospinal ligaments or the other or the peritoneals. I mean the fascias, and by doing so we will prevent further prolapses. And in some cases we can perform a total hysterectomy where the whole uterus is being removed, although this is not that common. And we can also have a condition in which the uh, the whole uterus can also prolapse and things like this. Well, so those were some examples, and we can also have rectal prolapse when the rectum will prolapse through the walls, like the because the rectum is neighboring the vagina, it can prolapse. And in this case, it's used the same method with the enterocele. A posterior wall of the vagina is cut and opened, and the ligaments will be sutured to the rectum and so that it doesn't prolapse anymore. So those were some brief examples of prolapsing. Hmm. まあ、いっぱい喋るとかあんま関係ないのね。